Hi, my name is Rachel Sussman, and I'm a urologist here at MedStar Georgetown University Hospital. I specialize in female pelvic medicine and reconstructive surgery with a focus on patients with neurologic conditions and urinary tract dysfunction. Today, I will be giving a talk on multiple sclerosis and lower urinary tract dysfunction as part of the MS 101 lecture series. So just as a brief outline, today I'll be going through the incidence of lower urinary tract issues in patients with MS. I'll talk a little bit about the normal neurourology physiology and how the bladder normally functions. Then I'll go over the things that can go wrong in patients with MS and how we evaluate for those problems, and as well as some of the treatments that we can offer. So as a brief outline, you can see here, this is a slide of various neurologic conditions and the percentage of patients that may experience some bladder dysfunction. You can see that multiple sclerosis has about a 50 to 80% risk of having any lower urinary tract dysfunction, which is among the highest of neurologic conditions. The reason that is that MS lesions can block or delay normal signals that control bladder function anywhere along the brain or spinal cord. So patients with MS may experience symptoms of frequency or urgency of urination, feeling like they have difficulty beginning their urinary stream, being unable to empty their bladder all the way, having to wake up at night to urinate, or leaking urine because they're unable to hold it back. To go over how the bladder normally functions, I think is helpful so that we can get an idea of how things can go wrong and how patients with MS may have issues. So the urinary tract is composed of the kidneys, the ureters, which are the two tubes that drain the kidneys, and the urine is then stored in the bladder. Our kidneys filter our blood and get rid of waste, and they excrete it as urine. So that urine is stored in the bladder, and the ideal function of the bladder is to store urine, a reasonable amount of urine, so you don't have to get up and go to the bathroom all the time, and that urine should be stored at a low pressure. The reason that is that the urine should flow from the kidneys down to the bladder, and it should sit there, and the urine ideally should not go backwards from the bladder to the kidneys. So sometimes in patients with MS can have issues where their bladder doesn't stretch as well as it should, and it gets stored at a higher pressure. That's something that we look for when we do a urologic evaluation, and that's something that's important because if the urine is being stored at too high of a pressure, that can put the kidneys at risk for damage long term. The other goal of the bladder is to be able to empty when we want it to. So you should be able to kind of empty on demand and quickly when you want to so that you're not leaking urine. In a normal bladder, what should happen is, this is a diagram here which shows this yellow line which indicates the pressure in the bladder. And really what happens is as our bladder fills, we sense that our bladder is filling and we feel that it is getting more full, but the bladder muscle itself should not squeeze until we're in the bathroom, it's socially appropriate, and we give ourselves permission to urinate. Sometimes patients with MS can have issues where their bladder becomes overactive and it starts squeezing before they grant themselves permission to urinate. And this can create frequency and urgency of urination, and it can sometimes cause the urine to leak out before they get to the bathroom. There are lots of nerves that go to the bladder, and this is really important just because some of the medications that we use target these different pathways. But just to go over briefly, this is a diagram of the brain and the spinal cord. And you can see here that the hypogastric nerves send signals to the bladder. And when these nerves are activated, this promotes bladder storage. So when these nerves stimulate the bladder, they cause bladder relaxation. And they cause the sphincter of the bladder, or the outlet of the bladder, to close so that the urine doesn't leak out. There's also the pelvic nerves that go to the bladder, and these, when they're stimulated, promote bladder emptying. So when these nerves are stimulated, they cause the bladder muscle to squeeze, and they cause the urine to empty. There are then the pudendal nerves that go to the skeletal muscles in our pelvis, which are our pelvic floor muscles. And unlike the bladder muscle, which we don't really have so much control over, the pelvic floor muscles are muscles that we have the ability to squeeze and release as you see fit. So for example, when you're trying to urinate, those pelvic floor muscles should be relaxed. And for example, when you cough or sneeze or laugh, you may unintentionally but deliberately kind of tighten those muscles to prevent any urine from leaking out. So MS lesions can affect any of these neurologic pathways, and they can cause problems with these functions of the bladder and the sphincter. This is sort of a complicated diagram, but just to show you, there's two neurotransmitters that we target when we use medications for overactive bladder. You can see here that the anticholinergic receptor on the bladder, when that's activated, that's right here, that causes the bladder muscle to squeeze. So we have medications where we can block that function to prevent the bladder muscle from squeezing when we don't want it to. There's another receptor on the bladder called the beta-3 receptor, and when that receptor is stimulated, the bladder relaxes. So we have other medications that we can use to target that receptor to help promote bladder relaxation. So when we think about the ways that the bladder can kind of go awry, I like to think of them in sort of two phases. You can have problems with filling and storage of urine, or you can have problems with bladder emptying. So what can go wrong with filling and storage? You could either have a problem where your bladder isn't doing what it should be, and what that could be is your bladder is overactive. It's squeezing when you don't want it to. And this can create frequency, urgency, and it can create leakage of urine before you get to the bathroom on time. You could also have a problem with impaired compliance of the bladder. So the bladder muscle doesn't stretch like it should. When this happens, as I mentioned before, the pressure in the bladder can be too high, which can cause leakage, and sometimes that can cause the urine to back up into the kidneys, and that can cause damage to the kidneys long term. So the bladder may be functioning well, but there may be other issues why we can't store urine like we want, and that's usually a problem where the outlet of the bladder is open, or there's not enough strength in the sphincters. This can happen with MS, but it also just happens commonly, for example, in women after childbirth. A lot of women develop leakage of urine with laughing or coughing and sneezing, and a lot of women with MS a lot of women who have had babies also have MS, and so this can be common among the MS population as well. And really this occurs because there's a lack of support in the tissue underneath the urethra. And so if there's not that good support, you may experience leakage when you stand up or when you cough or when you laugh. That can also happen in men. It's typically a result of prior procedures on the prostate in someone who's already seen a urologist before for another reason. So those are the issues that can arise in terms of storage and filling of the bladder. And then the other function of the bladder is to empty completely when it's time to urinate. And so there's two reasons that the bladder doesn't empty usually. One of them is it's a problem with the bladder. So the bladder muscle doesn't squeeze. And the other reason is that the bladder muscle does squeeze, but there's something that's blocking the flow of the urine. And there's various things that can block the flow of urine. One of them is the neck of the bladder or the internal sphincter, which we don't have so much cognitive control over, but sometimes that cannot relax. And then there's the external sphincter muscles, which are the pelvic floor muscles. And that's something that you could work with a physical therapist to help you learn to relax, because that's a skeletal muscle that you can actually kind of train yourself to relax better. And then there's a variety of other things that can also block the flow of urine. And, I won't get into all of them because this is really just a lecture focused on MS, but common things that could block the flow of urine would be an enlarged prostate in male patients, scar tissue of the urethra, which can happen in both men or women, or in women, they can have issues with pelvic organ prolapse, where, for example, after childbirth, the bladder can drop and kink the urethra, and that's something that can also be fixed. So that was a sort of very brief summary of everything that can go wrong with the bladder and the urethra and the sphincters. And I wanted to talk a little bit about what the goals of treatment are. So there's really two goals of treatment in patients with MS. Number one is safety. We want to make sure that there's nothing that is putting your kidneys at risk for damage in the long term. Sometimes you can have issues with the bladder that you may not be aware of. For example, some people think they're emptying their bladder all the way, but when we do an ultrasound, we see they're actually holding on to a lot of urine. So that's something we check when you come to the office. And in terms of safety, we just want to make sure that your kidneys are being protected, you're not getting frequent infections, and for patients who may have issues with urinary leakage, that there's no issues in skin breakdown from having to wear a diaper or a pad that's dirty. The second goal of treatment is symptom control. And really, that goal is to treat symptoms that are bothersome to the patient and improve quality of life for both patients and their caregivers. So one thing I just want to mention is that urinary dysfunction in patients with MS is a multidisciplinary problem, right? So you have to take into account someone's symptoms with their whole health picture. For example, if someone's having difficulty emptying their bladder and they're very mobile and they're able to catheterize themselves, that may be a good option for a patient like that. But if there's someone else, for example, who's having issues with frequency or urgency of urination, but they're mostly wheelchair bound and they're unable to transfer on their own, we may be able to help with frequency and urgency, but it might not improve your quality of life if you still can't transfer to get to the bathroom. So in those patients, we can think about other ways to help improve quality of life and contain drainage, perhaps with a catheter, to make sure that you're not wet and you're not leaking. I also like to take into account when I talk to patients about their problems, what's bothering them, what their goals are, what sort of support do they have at home, kind of what do they want out of treatment and what would make life easier for them. So one thing I just wanted to talk about very briefly are barriers to care in patients with MS. This was a study that was done out of NYU that looked at patients with multiple sclerosis and urinary tract dysfunction, and they questioned patients with MS why they didn't initially seek care for their urologic issues. About 9% of patients said that they felt embarrassed. 18% said that the doctor never asked about their problems. 20% said that they did talk about the problems with their doctor, but they never got a referral and they never saw the urologist. 18% said they had enough problems to deal with already. And 11% said that they did not think treatments were available. So these are all barriers that kind of impede patients with MS from getting the care that they need and that they deserve for their bladder. So just to talk to you very briefly about what would happen when you come to a urologist for evaluation of lower urinary tract dysfunction. A typical evaluation involves getting a history, getting the details about your urinary issues, and doing a physical exam, including a pelvic exam. We'll typically check your urine to see if there's any signs of infection, and we do a very easy test called a post-void residual, which is where we use an ultrasound, as you can see in this picture, to just measure how much urine is left behind after you urinate. Sometimes in patients who are not emptying their bladder so well, we will also get a renal ultrasound, which is a test that we might send you to the radiology department for. And this uses ultrasound to look at the kidneys, to make sure that there's no swelling of the kidneys. Can also look for kidney stones. And when they do this test, they can also measure to make sure that you're emptying your bladder well. There are some more advanced tests that we can do of the bladder for anyone that we have concern about bladder function or safety of the kidneys. And this is a test called urodynamics. So urodynamics is really the best test we have to understand what is happening in the bladder as it fills and as it empties. And how this test works is you come to the office, we put in a very, very tiny catheter into the urethra and into the bladder. And this is a catheter that's the size of a piece of spaghetti. It mostly sits there to function to measure the pressure in your bladder. We put another small catheter either in the vagina or the rectum, and that allows us to also measure pressure. And then we fill the bladder up with fluid. And as your bladder fills, it's an interactive test. We talk to you about how you feel, and we try and recreate the symptoms that you experience at home. When you experience those symptoms, we're able to see exactly what is happening in the bladder so that we can understand what's going on and so that we can target the exact problem when we talk about treatments. We then have you urinate with this tiny little pressure monitoring catheter in place, and that allows us to see how good your bladder muscles can squeeze and how hard it has to squeeze to get the urine out. We also put little stickers on the muscles of your pelvic floor that allows us to look at the tone in the muscles of your pelvic floor as your bladder is filling and as it's emptying. And in certain patients, we can use X-ray dye. So instead of just filling the bladder with water, we fill it with a little bit of contrast material that we can see on X-rays. So we can look at the shape of the bladder, we can look at the path of the urine as it leaves the bladder, and we can also look to see if there's any reflux of urine that goes up to the kidneys. So now you know everything about how the bladder is supposed to function and all the tests that we can do to look at your bladder. Let's talk a little bit about treatments and different things that we can offer. So for any patient, I like to start with the least invasive things first and then move to more invasive things. So there are lots of conservative things that we can do to help with bladder dysfunction. Number one, patient education. So some patients, for example, may have issues where they have to go to the bathroom really urgently and they leak on the way to the bathroom. But maybe they're only going to the bathroom 2 or 3 times a day because it's difficult to transfer and to get to the toilet. Sometimes something as easy as going to the bathroom in a timed fashion, so setting an alarm and trying to go every 3 hours, can really help tremendously with leakage. You can also do exercises to help suppress urges when the time comes, and you can do those on your own, or you can meet with a pelvic floor physical therapist that's specifically trained in urinary issues and that can help you learn these exercises. And there's certain modifications that you can make in your diet and your fluid intake that can help. There's a lot of irritants in the diet that can sometimes worsen overactive bladder, and I think I'll go over those on the next slide. But sometimes patients find that simply cutting these out of their diet can lead to significant improvement. Weight loss is something else that can help. So there are certain studies that show that if somebody loses about 8% of their body weight, they may have about a 50% improvement in their urinary leakage, which is pretty big. And then other considerations to take into account are just, where do you live? What help do you have at home in terms of transferring and mobility? What are your bowel movements like? There's a huge relationship between constipation and urinary symptoms because the pelvis is a crowded space. And if your rectum is full of stool and that's pushing on the bladder, that can also make your urinary symptoms worse. So I always ask patients about their bowel habits and try and get them on a good bowel regimen to help with constipation. Here's the slide I was mentioning about common bladder irritants. So the most common irritants in the bladder are coffee, soda, tea, spicy foods, acidic foods, artificial sweeteners, alcohol, and tobacco. I tell all my patients I'm not here to ruin anyone's life. I drink coffee every morning, so I'm a realist, and I understand that, you may not be able to cut everything out of your diet, but for example, for me anyways, I don't drink coffee when I'm going on a long car ride because I know I have to stop and go to the bathroom, so I try and time it appropriately when I'm going to be near a bathroom, since that's a common bladder irritant, makes you have to pee. There's other things that we can do just to manage incontinence. So if you are leaking urine when you don't want to, you can buy pads to wear to help protect your clothes from getting wet. They sell disposable pads for both men and women that you can buy at the pharmacy. They also make really nice underwear that looks pretty much like normal underwear that's absorbent and washable. It's good for the environment, and it doesn't feel so much like you're wearing a pad. And there's also some good creams that you can put in the groin area. So if you are having leakage of urine, it protects your skin from any breakdown or any rashes. For patients that do have a lot of leakage and that may have difficulty getting to the bathroom in time, there are also external catheters that can be used to help contain urine. And some patients may find they may just want to use this at night because it's difficult to get in and out of the bed. But for men, there's a condom catheter, which is basically what it sounds like. It's a condom that goes on the outside of the penis and it collects urine into a drainage bag. And for women, there's also an external catheter called the PureWick system. This we've used in the hospital for many years. Unlike the condom catheter, it has to be plugged into a wall. So it's really best for someone who's kind of laying in bed, so it can be used at night, or for someone who's in bed during the day, this can also be used, and it just sort of collects the urine, and instead of going into a pad, it collects it into a container that can be put at the bedside. So that's sort of conservative management. And then there's medications that we can use. So for patients with overactive bladder, and again, that's patients in whom their bladder muscle is squeezing when they don't want it to, it's creating frequent urination, urgent urination, and sometimes leakage of urine before you can get to the bathroom. There are two types of medications that we can use, and it goes back to those slides with the neurotransmitters that I mentioned. The first type of medications are called anticholinergics, and how those work is they say to the bladder, no bladder, do not squeeze. They basically block the receptors on the bladder that tell it to squeeze. Those medications have been around for many years. They work very well. There's lots of different types. Side effects of these medications could be, and it kind of varies by medication, but dry eyes, dry mouth, constipation, and rarely confusion. There's another newer class of medications called beta-3 agonists, and those work for the same goal to relax the bladder, but instead of saying no bladder, don't squeeze, they say yes bladder, please relax. And so these medications stimulate that beta-3 receptor that causes bladder relaxation. There's two of them, mirabegron and vibegron, and they're pretty well tolerated. They have much fewer side effects. Side effects that could develop could be headache, or mirabegron can have a slight increase in your blood pressure, although it's not common. The biggest side effect of these medications are cost, because they're not generic and they can be a little bit expensive, although there are some good coupons that are put out by certain of these companies, and also some insurance companies do cover them. So these are two medications that work really well, and they even work better together than they do alone. So you can take both of these medications together and they have a complementary effect and they work well to relax the bladder. If medications and behavioral changes or physical therapy don't work, There's also what we call third-line therapies for overactive bladder. And when we're talking about all patients with overactive bladder, there's really three third-line therapies. There's bladder Botox, and then there's two treatments that sort of focus on the nerves that go to the bladder, and those are called peripheral tibial nerve stimulation and sacral neuromodulation. I have an asterisk here on these slides because these two types of treatments are not FDA approved for neurologic bladder because it's very variable in patients with MS how well we can stimulate these nerves, but there are some small research studies that in select patients these therapies can work. So to go over bladder Botox, which works very well in patients with MS, Botox is something you may have heard about. Plastic surgeons may inject it in the forehead to help paralyze these muscles and prevent wrinkles. We can also inject it into the bladder to relax the bladder muscle and prevent it from squeezing too frequently. Botox is a toxin that's produced by bacteria, and it temporarily paralyzes the muscle. It relaxes the bladder so that it can hold more urine, and it improves frequency and urgency in leakage. This is something that can be done with a cystoscope, which is a small camera that we use to look inside the bladder, and it can be done in the office with local anesthesia. On average, Botox lasts between 6 and 9 months, but it can be repeated as soon as every 3 months, and in some patients, it lasts longer than a year. Botox works incredibly well. The risks of it are you can have a little bit of bleeding, you could get an infection around the time of the procedure. The biggest risk is that in some patients it works, but it works too well. It paralyzes the bladder too much, and then they have difficulty emptying, which usually only lasts about 30 to 60 days, but it's something that you have to know ahead of time and be willing to accept. So if you take all comers, patients with MS, without MS, the risk of having to catheterize your bladder after a procedure like Botox is about 6%. So it's present, but about 94% of patients don't have to do that. Patients with MS do have a slightly higher risk of having to catheterize, and I think I have on this slide a study of patients with Botox and MS, and this was a study that was done that looked at the risk of having to catheterize after a Botox injection, and overall it's about 15.2%. So that was compared to about 2% of patients who got a placebo or kind of like a fake injection. If you look here, though, you can see on the left-hand side of this slide, at least 80% of patients had a more than 50% reduction in the amount of leakage that they were having, and about 53% of patients had a complete resolution of leakage. So some patients might say, wow, if I'm not leaking at all, I'd be okay catheterizing 1 or 2 times a day if I have to, because they're so happy with the results of the procedure. The other thing to look at on the right side of this slide is the social embarrassment score. And you can see that patients undergoing Botox on this purple line had a significant improvement in their social embarrassment scores than compared to patients who did not receive Botox. The other two therapies I'll go over very briefly. I do think that there is some role in patients with MS, but we need a little bit more data because they haven't been studied in this population so much. The first one is basically like acupuncture. It's called peripheral tibial nerve stimulation. And how it works is you come into the office, we put a tiny little acupuncture needle into one of the nerves in your ankle, that when it travels back up to the spine, it goes to the same nerve roots that go to the bladder. You come in once a week for 12 weeks, and we stimulate this nerve for about 30 minutes. It's very minimally invasive. It's low risk. The biggest risk is it's just time intensive, and you have to come to the office once a week for 12 weeks. And if you have a good response, we typically recommend continuing treatment about once per month. Again, this is not FDA approved for patients with MS, but it is a very low risk option, and it's something that could be tried, and in some small research studies has been shown to be effective. The other treatment is a different type of neuromodulator, which doesn't involve coming to the office every week, but it's basically a pacemaker for the bladder that's placed surgically. Historically, this type of pacemaker was not compatible with MRI machines. So it was not placed commonly in patients with MS because, as you all know, you have to be monitored not infrequently with MRIs. But actually, just last year, the FDA approved a device, which we've been using, that it works in the same way, but the device itself can be used in an MRI machine. So we're just now starting to gather more information on patients with MS. How this works is it's a tiny little lead that goes into the sacral nerve roots in the spine, and it's placed to a stimulator that constantly sends signals to these nerves to basically create white noise and get rid of any of the false signaling going to or fro, telling you when your bladder is sending false signals and helping with overactivity. It is FDA approved for overactive bladder that's not neurogenic in nature. It also helps with bladder emptying because it can actually help the bladder to squeeze and function better. And it's also FDA approved for fecal incontinence or incontinence of stool. Again, more data is needed on this therapy for MS patients. There are some small series that have been done in patients with MS that show it does work pretty well for overactive bladder and patients who may have issues with retention due to abnormal functioning of their sphincter. It doesn't work so well to help the bladder squeeze if the bladder isn't squeezing on its own. But again, we just need more research to be done. So the other issues we talked about is why someone may not store urine. It might be because they have stress incontinence or their sphincters aren't holding back the urine. And again, these are more general urologic issues. They can happen in MS because all patients can have these problems. So I'm just going to go through them very briefly. But for stress incontinence, and that's really leakage of urine with laughing, coughing, sneezing, exercising, transfers, behavioral changes can help. Pelvic floor exercises or pelvic floor physical therapy can help. Weight loss can help. And then they make little inserts for the vagina that women can place that put a little pressure underneath the urethra, and they help create a little support under the urethra. You can see here, this is called an incontinence pessary. And then for men, they make a little external clamp that's made of foam that can be put on the penis, and it can prevent the flow of urine, and then you take it off when you want to urinate. There are surgical treatments for stress incontinence, and again, I'm just going to go over these very briefly because they're probably less relevant to multiple sclerosis, but there are injection therapies, just like we stole from plastic surgery to do Botox in the bladder. Plastic surgeons put fillers in the muscles of your face right here. We can put those fillers in the urethra to help narrow it and prevent urine from leaking out. We also have sling procedures that can be placed in women with incontinence. And for men who have significant stress incontinence, we also make a urinary sphincter, which is a little balloon that's placed around the urethra, and it keeps the urethra closed. It's attached to a small pump that sits in the scrotum, and when it's time to urinate, you squeeze the pump, the fluid goes out of the balloon, it allows the urine to flow out, and then it fills back up. So those are all the issues with filling and storage of urine. The issues with bladder emptying can be a little more difficult to treat. So basically, if you're having issues emptying your bladder because there's something blocking the flow, the treatment is get rid of whatever is blocking that flow of urine. So in men, that might be an enlarged prostate, and we can give you medications to relax the prostate or even do surgical procedures on the prostate. If there's a stricture or a narrowing of the urethra, that can be corrected by stretching that out or treating it surgically. In women who may have pelvic organ prolapse or a dropped bladder, that can be fixed by wearing something like a pessary that I mentioned before, or with surgeries, or with pelvic floor physical therapy. And if you're having issues emptying because your muscles aren't relaxing when it's time to urinate, you can also go to a pelvic floor physical therapist to learn how to relax those muscles appropriately. For patients who cannot empty their bladder, really we can teach you how to empty your bladder with a catheter. That's the easiest thing to do so that you can just catheterize a couple times a day to empty your bladder when it's time. That would be a little catheter we give you. You put it in, you empty the bladder, you take it out, you throw it away, and you use a new one the next time to help empty when you can't go. There are other treatments for patients who don't want to catheterize and can't empty their bladder. A suprapubic catheter can be placed, which is a little tube that goes directly into the bladder through the abdominal wall. And I think I have a picture on the next slide. And it drains the urine so that you're able to empty and you're not leaking and the urine is contained in a bag. And you can also place a urinary catheter through the urethra, so either through the penis or through the urethra in women, and that also drains the urine into a bag, although that's not so preferred in the long term, just because it can cause issues with erosion and it's also a little bit more uncomfortable. So here's a picture here of somebody who's doing an intermittent catheter, basically sitting down on the toilet, emptying the bladder. The goals of intermittent catheterization are just to drain the bladder regularly, to stay dry, and to avoid overfilling of the bladder. A suprapubic catheter, as I mentioned before, is a small tube that can be placed through the abdominal wall, and it drains urine into a drainage tube. And that tube is then hooked up to a bag that collects the urine, and you or a caretaker can empty that bag whenever it's full. So there's different types of bags that can be used. There's a leg bag that's seen here on this slide, where the bag is basically attached to your leg and it can be placed under pants or under a skirt, and it's really not visible to anybody else. There's then a bigger bag, which can be useful, for example, when someone's at home or they're sleeping overnight because it's a little bigger and you don't have to empty it as frequently. And for someone who's using a wheelchair, you can get one of these little bags that you can put on the back of your wheelchair. You can put the catheter drainage bag in there and then nobody sees it. There are some other things that we can do for bladder emptying. I'll go over these briefly because they're really a little bit more experimental. You can do Botox, like we can paralyze the bladder muscle. You can do Botox of the sphincter muscles to help paralyze those if that's the issue that's causing a blockage in the flow of urine. When you do that, it can also cause some leakage, but that's an option. You can do a surgical diversion of urine. So instead of having a drainage tube, you can have a little bag where your urine drains into a segment of bowel that collects in a bag on your abdomen. And like I mentioned, the sacral neuromodulation, I have a question mark here on this slide because this does work for patients whose bladders don't squeeze so well, but it hasn't really been studied in MS population. So I think a little bit more research is just needed there. We've gone over a lot today and we're just about to wrap up, but I did just want to go over a couple things just quickly about urinary tract infections, since this is a common problem in many patients and in particular in patients with MS. But there's a real clear distinction that we need to make between what is a urinary tract infection and what is asymptomatic bacteriuria. So many patients with MS can have urinary tract symptoms that are not caused by infections. And so an infection occurs when you have symptoms of an infection. So that could be fevers, chills, pain, burning with urination, an acute change in your urinary symptoms. So something that's abnormal for you. Or you could have a flare of your MS. Sometimes that can be caused by a urinary tract infection. And usually I think of something as an infection when you have symptoms, you take an antibiotic, and then those symptoms go away. So for example, a lot of patients may have symptoms of frequency and urgency of urination that sound like an infection, but if they take an antibiotic and it's not getting better, that's probably more likely just occurring because of dysfunction in your bladder for some other reason. One thing that's been studied extensively is the smell of urine, and the smell alone is not typically thought of as a sign of an infection and does not need to be treated. So asymptomatic bacteriuria is something that happens just when bacteria live in the urine, but they're not really causing symptoms. So one thing I think a lot of people don't understand is that the urine sometimes just has bacteria in it. And if it's not causing symptoms, it doesn't need to be treated, because if you continue to treat bacteria in the urine when it's not causing symptoms, you can get issues with bacterial resistance, and it can cause problems later down the line if you do have a true infection. There's lots of things, though, that we can do to prevent infections. One of them is making sure that you're emptying your bladder well, that we're minimizing leakage. And then one of the most important things you can do is just stay hydrated to flush out all the urine and make sure that you're emptying well. Cranberry supplements work very well to prevent specifically E. coli infections, because cranberry actually prevents E. coli from sticking to the lining of the bladder. And then there's other supplements we can use like D-mannose or methenamine that also help prevent infections. And then in women after menopause, vaginal estrogen is the number one thing that we can do to prevent infections. So after menopause, when women have less estrogen around, what can happen is the pH of the vagina can change, and it can make it a more favorable place for kind of the bad bacteria that cause infections to grow, and a less favorable place for all the good bacteria like lactobacillus to grow. So if you take women after menopause who are getting about 6 infections a year, and you give them all a vaginal estrogen cream to use, on average, they'll go down to getting only 1 infection a year. So it works incredibly well. So any woman after menopause who's having infections, unless they have a reason that they can't be, should probably be on a vaginal estrogen because it will help them. So that was a lot of information. I'm happy to answer any questions as they arise. I just wanted to list here the different locations where I see patients. I also have on here the number to central scheduling. If anyone wants to see me as a new patient to talk about their urinary tract symptoms, I'm happy to see you anytime.
Okay, so that was a fantastic lecture by Dr. Sussman. And now we have a lot of questions. Some of those have been published. those questions that have been published, she's going to answer live right now. She's here with us. So uh, it was a fantastic, phenomenal presentation by Dr. Sussman. So now I'm just gonna leave you with her. Try to squeeze out of the information that you can get from her, and then at the end of it, as you can see, one of the messages that has been published. Um, there is their contact information for you to call her, and you can get a consultation with her for your urinary symptoms. So without further delay, I'll leave you with Dr. Sussman.
All right, so thank you so much to Dr. Serrano and for the department for putting this lecture together, and it's very nice to meet all of you virtually. There were a lot of questions came in, so I'm going to just start from the beginning, and I'll try and kind of address these one by one. Yes, the webinar is going to start shortly. That was the first one. Okay, so what are the best non-surgical treatment options for light but chronic urinary incontinence, and what results have been seen by the LEVA? So for those of you who don't know, the LEVA, which I think you're referring to, is a device that you can purchase at home to help you with pelvic floor muscle exercises. And sort of as the talk went over a little bit, really the approach to incontinence depends on what the problem is. So really I think about incontinence as two main types. One is urgency incontinence, or the type of leakage that happens when you have the urge to go and you can't make it. The other is stress incontinence, which happens like with coughing, laughing, or sneezing. And pelvic floor muscle exercises can actually help with both. So that's a great option. There's been a lot of research onto sort of what's the best modality to help with pelvic floor muscle exercises. And really, I think it's the one that facilitates compliance, or just that you're going to use it. So some people find using devices like the LEVA cumbersome. Other people find that it's really encouraging because they spent the money to purchase the device and it encourages them to do it. It's kind of like going to Weight Watchers. If you sign up, you're going to be motivated. So I think it's the same thing with purchasing one of these devices, but I wouldn't really recommend one more than any other. We do have a lot of really great pelvic floor physical therapists at MedStar that can help you to identify your pelvic floor muscles and just work with you on a plan for pelvic floor muscle strength. And so that's a great option. Question number 2 was, I was on a long-term antibiotic for MS-induced UTIs, which unfortunately resulted in a severe case of organizing pneumonia. I can no longer take that antibiotic. Is there any other long-term treatment for MS-induced UTIs, either antibiotic or another form? So I kind of went over this in the last slide, but one thing I would just really make sure of is hydration. That's a really good thing to do to help prevent infections, preventing constipation, urinating frequently, cranberry supplements if you're growing out E. coli bacteria. And if you're a female patient that's after menopause, something like a vaginal estrogen works really, really well. The other thing, as I mentioned also in the talk a little bit, was just making sure you're not treating bacteria that aren't really responsible for symptoms, because it's actually really common to have bacteria that live in the urinary tract. And the only reason to treat them is if they're associated with urinary tract infection symptoms, and those symptoms improve when they're treated. All right, next question is, how can you differentiate between urinary issues from an aging bladder and MS? And what do you think of tamsulosin, and what would you recommend? So that's a really difficult question because a lot of patients have normal bladder issues that happen as we age, overactive bladder and enlarged prostate. And some of this can be related to the MS and some of it can. And I think the first step in getting to the bottom of that is just to meet with a urologist like myself or one of my partners. Dr. Brown is one of my partners who also specializes in neurologic bladder dysfunction, and kind of just delve into it a little more. For those of you who are not familiar with tamsulosin, that's a medication that's called an alpha blocker, and that helps to relax the bladder neck and the prostatic urethra to kind of allow the urine to flow more easily. So in men, sort of around 50, 60, the most common reason men have urinary symptoms around that age is from an enlarged prostate. So that's often my first step, is to try that medication, because just because you have MS doesn't mean you also have an enlarged prostate. So I think just really kind of seeing a urologist, talking about options, and trying different things is a good first step. Are there any other recommended treatment modalities available to assist with managing a neurogenic bladder? I currently take Myrbetriq and get Botox shots to my bladder, and I'm thinking of not continuing with the Botox injections. So I did go over this a little bit in the talk, and I kind of went over all the therapies, so I hope I answered that question. One thing I didn't go over about Botox, just because it was a little kind of like in the weeds, is that there's different doses that we can use of Botox. So you can start with 100 units, but you can increase the dose to 200 units. So if 100 units don't work, you can try a higher dose, and sometimes that works. Sometimes you can use other medications like anticholinergics or some of the other therapies that I mentioned as well. Is it normal to hold your pee even when you're not trying, and then all of a sudden feel like it's an emergency to get to the restroom? And yes, that is a common problem that patients in MS have, because patients can have issues with, basically we call it an overactive bladder and an underactive bladder at the same time, meaning your bladder squeezes when you don't want it to, and it creates that urgency, and then you feel like, oh my God, I gotta go, and it leaks out. But then when you want it to squeeze, it doesn't. So that can be very difficult to treat, but for somebody who's willing to catheterize, a really great option in that situation is to give you medications or Botox to really paralyze the bladder muscle so it just doesn't squeeze, and then you can catheterize when you want to empty, and that can give you a lot of control back about your urination. How can we find out if our urologist understands MS and its impact on the urinary system? So that's a really good question, because a lot of general urologists don't necessarily focus on neurologic disorders. At Georgetown, both myself and my partner, Dr. Elizabeth Brown, specialize in neurologic conditions that affect the bladder, and certainly there's lots of other doctors out there too, but I think just asking is a good option. How do you overcome incontinence? I think that's a complex question with a lot of different answers, and I hope I answered those throughout the talk. If I didn't, you can feel free to add them to the question box now. Are you familiar with Eucora as prevention for UTIs? If so, I find D-mannose 900 a day to help tremendously. Can you compare the two? So D-mannose is a great option. If you find that works, I wouldn't change a thing. There really aren't so many studies looking at supplements for UTI prevention, because supplements are not controlled by the FDA in any way, so it's really hard to know what's in them. Eucora is a company that I think makes a bunch of different supplements with lots of different components. The one supplement that's been studied the most is cranberry supplements, and we know that that works very well specifically to prevent infections with E. coli. The two supplements that have been studied in clinical trials for cranberry are Theracran and Illura. Those are two over-the-counter supplements that you can buy on Amazon. So again, that's Illura, E-L-L-U-R-A, or Theracran, that's T-H-E-R-A-C-R-A-N. Eucora is another one that a lot of my patients have success with. I just haven't seen the studies on them, but I think anything that works for you is great. My insurance company has stopped covering my Detrol. What other meds do you recommend? So this is a really frustrating comment, I'm sure, for you as a patient and also for me as a doctor, because we really have to fight with insurance companies to get the medications that work covered. Honestly, a lot of the anticholinergic medications all work very well, so I usually just try and work with patients and their insurance company to find one that's affordable and one that works. Some of the newer medications do have coupons available. Those are the beta-3 agonists, just because they're not generic and they're relatively new. So like the company who makes Vibegron has coupons out to make the drug a little bit cheaper, but that's just a frustrating part of trying to get medications for bladder dysfunction. Does the Mona Lisa procedure have an impact on the pelvic floor? So for those of you who are not familiar, the Mona Lisa is a laser treatment of the vaginal epithelium. The Mona Lisa procedure really works to kind of treat vaginal atrophy or vaginal dryness. So it doesn't really affect the pelvic floor. And I think there's more research that needs to be done on laser therapy for the vagina. When you look at biopsies of the vaginal tissue before and after Mona Lisa, you do see some changes under the microscope that look similar to if you gave a vaginal estrogen. But Mona Lisa is not covered by insurance. You have to pay a lot of money out of pocket. I think for most women, I'd say just use a vaginal estrogen unless there's a reason that they can't. Is caffeine-free tea bad? Caffeine-free tea is probably better than caffeinated tea. and probably water is better than both of those. But I think if you had to pick one or the other, I'd go caffeine free. What are cognitive risks of medication, especially anticholinergics? So this is a really good question. Anticholinergics can cause some confusion, and rarely, there's newer studies that have come out that show like there might be a risk of dementia in patients using anticholinergics. There are two anticholinergic medications that are less likely to cross what's called the blood-brain barrier, and they're less likely to cause confusion. Those medications are Sanctura and Enabalex. So in patients that do have any confusion or that are older, I usually pick those medications as opposed to other anticholinergics, or if your insurance will cover it, a beta-3 agonist, which doesn't have that risk. Okay, those are all the ones we published already. Let's see the others. Do you know what percentage of MS patients that are currently taking the shots is helping their urinary incontinence? So if the shots you're referring to are the Botox, there's about an 80% of patients see a greater than 50% improvement in their incontinence, and that's for patients with MS. Can you put up the slide with the two new medications? I don't know how to do that, but I'll tell you what they are. They are Mirabegron and Vibegron. The brand names of those are Mirbetriq and Gemtesa. So I think Dr. Serrano is going to publish this later, and so you'll be able to see them. I just don't know how to write them now. Okay. With my MS, what is the relationship between my bladder urgency and my fecal urgency? That is a very good question. So there's a huge relationship between your bladder and your fecal urgency because the nerves that go to your bladder are the same nerves that kind of control your bowel movements. So, a good option for treating both of those things is that sacral neuromodulator or a pacemaker that I mentioned, but it really kind of depends on where your MS lesions are. That may or may not work, and it just depends on sort of how well those nerve pathways are functioning. But I will say for all patients with fecal urgency or fecal incontinence, there are lots of things that we can do to treat that. The number one thing that you can do is take a daily fiber supplement, because fiber helps to bulk your stool and it helps to prevent leakage of stool when you don't want it. It makes the stools a little bigger so you can feel them and hold them back. And the one thing about fiber, which I tell all patients, is you have to give it a fair shot. You have to take fiber every day for at least 2 to 3 weeks before you decide whether or not it works for you, because it takes a long time to kind of work and to see those changes. And, oh, you were referring to the ankle shots. So to be honest, I don't know of any research studies that have studied PTNS, which are those shots, in the MS population. So this is something where we need more work and more research, but it is something that is usually covered by insurance. So if you have the time to do it and you're interested, it's not so much risk other than you have to come to the office every week. I wish I had more data to point to and to give you an exact number, but it just hasn't been studied so much in the MS population. And I think that was all of the questions. So let me switch back to Dr. Serrano and he'll kind of close things out.
Take care and stay safe and God bless you all.